Hi everyone, my name's Sarah Moxon, and I'm going to try and talk to you in 3 minutes about inpatient care for small and sick newborns, which is an issue very close to my heart as I am a neonatal nurse. I have the co-authors listed here, and I hope that you'll come and see the poster a bit later. We're kind of hidden in the corner, so I hope you won't forget the small newborns. This is a figure that shows 4 worlds. In the top left corner, you can see high-income countries, where 11 million births take place. Almost all of these babies have access to neonatal intensive care. When you look at the bottom half of this figure, you see that there are nearly 90 million births. Most of these babies do not have access to special care if they're born small and sick, especially the 50 million that are born in low-income countries at home. If we look in the top right corner, we have middle-income countries, where 34 million births take place. Some of these babies will have access to special care if they're born small or sick, but the quality of the care is highly variable. A recent study in The Lancet by Buta et al., published in 2014 as part of the Every Newborn series, showed that optimal inpatient care in a special care baby unit could avert 70% of neonatal deaths due to preterm birth complications. Preterm birth is now the leading cause of death in children under 5. So I'm going to try and explain bottleneck analysis in just over 35 seconds. Not an easy task. But as part of the Lancet and the Every Newborn process, a structured tool was developed. This was based on 7 health system building blocks and was designed to identify the factors hindering the scale-up of inpatient care for small and sick newborns. It was applied in 12 countries, 6 in Africa and 6 in Asia. From this, we generated heat maps, we carried out a thematic analysis of the reported bottlenecks. We proposed evidence-based strategies and program learning, as well as priority actions. I obviously don't have time to go into all of the results now, happy to discuss them, but to give you some highlights. First of all, we identified a critical human resource gap for a global neonatal nursing cadre for small and sick babies. I've heard a lot about midwives today, but I also want to hear about neonatal nurses. Budget allocation to avoid catastrophic out-of-pocket payments for newborn inpatient care. These are babies that may stay in facilities for a long period of time. And finally, the importance of reducing the fatalism that all small and sick newborns will die. We need to increase awareness at community level and support family-centred care that includes mothers and includes the wider family, including kangaroo mother care. Quality of care needs to be improved everywhere to reduce deaths and to improve the lives and quality of life of small and sick babies into the future. Thank you. And thank you to all the co-authors.
Hi, I'm Isabel Lang, and I'm presenting on behalf of my co-authors at the LSHTM and at CERUD in Benin about women's perceptions of Benin's free C-section policy. And before the policy came into place, a C-section, women would be expected to pay about 100,000 CFA for a C-section, which is about 110 pounds. And just to put that in perspective, a school teacher might earn 30 pounds per month, a housekeeper 10 pounds a month, so these are really catastrophic costs for families. But then in 2009, a policy was introduced that gave a lump sum, that reimbursed a lump sum to hospitals for each C-section. And this didn't necessarily represent the real cost of the C-sections in each setting. So some hospitals were able to profit from this policy and some were at a loss. And this policy is one of many similar initiatives addressing user fees in maternal health in the region. They started in a wave in the 2000s as part of efforts to reach the MDGs in the critical moment, and hope to improve, to increase facility-based deliveries and alleviate the financial burdens of care on delivering women. So we wanted to understand women's experiences of care, their perceptions of care in maternity wards now that a large financial barrier was removed. How did they experience care and C-sections? So as part of FemHealth, which was a larger interdisciplinary evaluation of these policies in 4 countries, we undertook a qualitative study that consisted of participant observation and in-depth interviews. We started in 5 hospitals, interviewing 30 women who had C-sections, and then moved to 2 case study sites where we conducted a further 30 interviews with women, but this time with women where the care had been observed night and day. We had informal discussions with health workers about their care to really understand, to be able to triangulate the sources of information. And as mentioned earlier, we understood quality of care to be made up of both the provision of care and also the experience of care. So, what did we find? Just a few highlights are that women still feared C-sections. They were not a preferred method of giving birth. But health workers found that it was now easier after the policy to carry them out. There were less delays for them, and they didn't have to have this worry about putting a financial burden on families when they prescribed a C-section. There were blurred lines of consent. Many women weren't informed about their procedure before they were going to have a C-section. And all of this led to C-sections being perceived as a threat by many women, especially in certain settings. That said, though, the costs were more manageable now without this. There were still many bribes and informal payments that remained, and that created a lack of trust for some women with the health center. So what we saw was that even with the removal of the financial burden, the social signification of a C-section means that there's still largely an undesired medical act. And so this should be considered, and the potential for over-medicalization, when developing policies that are also meant to increase access to facilities for labor. Just as these dynamics of obtaining consent should also be looked at when you remove this barrier, and this time to collect money should also be addressed at the maternity ward. And if you go to the poster, I have more information on the 2 different contexts, the case study sites, where you can really see that context and leadership play important roles in how the policy is implemented, and including in terms of the perverse effects such as informal payments and diagnosing the need for a C-section. Thank you.